Thank you very much, Liz, for those kind words. Hardly recognised myself. This is my first time in Australia. I think it's absolutely brilliant. And I want to thank the organising committee for the invitation. I'm very, very honoured to be here. And I'm very happy to see you all up so early in the morning and attending this talk. I have picked up a little bug, probably on the airplane on the way over, so I'm a little bit croaky. I hope you can still hear me at the back. So in terms of protocolised weaning, does it work? Well, there's a lot of indecision in relation to this. Yes, it will work in some cases, and no, it won't work in other cases. And it would really, as we say in Northern Ireland, it would do your head in trying to make the decision. And I have an interest in this from the early days when I was doing my PhD. I was very influenced by the work coming out of the US, which was showing positive results for protocolised weaning in terms of reducing times on ventilation and ICU stay. And I conducted the first UK trial. It was a non-randomised but a controlled trial in the UK, and it didn't work. And I kept thinking, well, why didn't it work? And when it's your PhD, you sort of want to have a positive outcome. And anyway, this has really steered a lot of the research that I've got into since then. So what I'm going to talk about today is the international evidence for protocolised weaning. I'm going to then move on to look at why protocols work in some situations and why they don't in others, and suggest some factors that contribute to that variability. And then I want to end off with some considerations about where do we go from here. So the Cochrane Review for Protocolised Weaning was first published in 2010, and I've just updated it and submitted it, so it should be published within the next 2 weeks, the update. So you're going to see the results of that firsthand. The population was mechanically ventilated adults in all types of ICUs. We looked at interventions that were protocolised weaning, and they could have been either professional-led or computer-led, and the comparator was no protocol at all. The primary outcome was the duration of ventilation, and secondary outcomes were duration of weaning, ICU and hospital length of stay, re-intubation and adverse events. And we included studies that were quasi-randomised trials as well as randomised trials. So in describing the population then in the setting, the ICUs in which these studies were conducted were medical, surgical, neurological and mixed medical surgical ICUs. There were 17 trials included in the review, and they came from 4 continents. And as you can see from the graph, the majority of them were conducted in North and South America. There were 4 conducted in Europe, and 3 in Asia, and then 1 in Australia. In describing the intervention, protocolised weaning, there were a variety of protocols, and about 53, just over half of them, included a daily screen for readiness to discontinue from mechanical ventilation as part of the protocol. So that meant that from day 1 of coming into ICU, they included a daily readiness, a daily screen for readiness to wean or to discontinue ventilation. The criteria they used for their daily screen varied from 5 to 14 criteria, and I think 14 is a little bit excessive. But the protocols themselves were mainly spontaneous, they were either professional-led, the majority of them, and just 4 of them were computer-led. Of the professional-led protocols, the majority of those had spontaneous breathing trials, and the others had stepwise reductions in ventilator support. The spontaneous breathing trials, the duration of those trials varied anywhere between 30 and 120 minutes. And the majority of those used CPAP, again with the variable parameters, 2 to 5 centimetres of water, and or pressure support with 48 centimetres of water. In terms of stepwise reductions, 4 trials used those, stepwise reductions in support, and that was in SIMV, so reduction in respiratory rate, pressure support, or in PEEP, or a mixture of these. And again, the parameters, what they reduced down to, also varied anywhere between 0 and 6 breaths, 4 to 8 of PEEP, or 5 to 8 of PEEP, or 4 to 8 of pressure support. The computer-led protocols, 3 of those were Draeger, and the Draeger system will titrate pressure support in response to the patient's, what's happening with the patient's breathing. And they will also initiate a spontaneous breathing trial. And then the other one was a very early model, non-commercial computer, which was a SuperSport model. That was the first trial of 1993. And it titrated respiratory rate and pressure support in response to the patient's ventilator parameters. So that's a description of the protocols that were used in these trials. So what about what they compared them to, the comparator? Well, that was called usual practice. And 71% of trials did not explain what usual practice was. Now, I'm the president of the European Federation of Critical Care Nurses, and I know from those countries which are involved in the federation that there is no such thing as usual practice. It's completely different everywhere you go. So it seemed rather strange to me that usual practice would not be described in the trials. 5 trials did explain what usual practice was, and that's what you see here in the left-hand column. It was usually stepwise reductions in support of respiratory rate and pressure support and PEEP. And in this column, the middle column, I've shown what they compared it to, what their intervention arm was. And you can see that the 4 computer-led trials actually described their usual practice when really only one of the professional-led protocols, the one from Kyoto in Brazil, described usual practice. So what about the quality of the trials? In this review, we used the Cochrane risk of bias tool to assess quality. And quality is generally assessed in 7 domains, 7 main areas. And here you see a summary chart. So the green highlights those that are low risk of bias. Yellow highlights where things were unclear, and that's generally because they weren't reported. And red signifies high risk of bias. And 2 trials had high risk of bias in relation to randomization because they were quasi-randomized trials. So they randomized according to hospital number or sequential admission. We judged the blinding of personnel as quite high for all studies because it's totally impossible to blind personnel in these type of studies. We were a bit disappointed that blinding of outcome assessors was actually not reported in many of the trials. So in general, sort of moderate quality of trials. Now, before I go on to the results, I just want to mention a little bit about the data synthesis because this is a little bit different from what you might be used to. Continuous variables, that are those that are duration of mechanical ventilation, weaning duration, ICU stay. As you can imagine, these are going to be skewed data, with generally patients being, the duration of ventilation being a couple of days and some patients having a longer period of time on ventilation. So the data is generally skewed. And in order to put that into a meta-analysis, you have to log transform it, which sort of helps to normalize the data. So we had to ask some of the authors for their raw data in order to do log transformation, and we received that from 6. In 10 studies, we couldn't contact them, so we had to use what they reported, either mean or median, and we had to approximate the mean and standard deviation on a log scale. And one study, we weren't able to use the data because they didn't report all of the data, they just reported the mean. So then the mean difference between groups, which is going to be on the log scale, was exponentiated to give the ratio of geometric means on the unlogged scale. Now for some, I'll explain that in really simple language. It basically means you take the data, you have to log transform it for analysis, But it doesn't make any sense to clinicians when you present the results that way, so we have to convert it back. But when you convert it back, you can only convert it back to a geometric mean, a ratio of geometric mean. And so this is reported as a percentage increase or a percentage reduction in the geometric mean in the protocolised group in comparison to the control group, and that's for ease of understanding. So I hope you get a sense of the understanding of the data. We also thought that there were some things that might impact on particularly our primary outcome, duration of mechanical ventilation. So we decided we would do subgroup analysis by type of ICU, type of delivery, and by the type of protocol, if we were able to do that. So in this slide, you see the forest plot for the primary outcome, the duration of mechanical ventilation, and 14 trials provided data for this outcome. At the very bottom of the forest plot, you can see the summary statistic, the diamond, I've circled it, and it sits very clearly to the left of the line of no effect, which is showing that it favours protocolised weaning in general. So that's a 26% reduction in geometric mean in the protocolised group in comparison to not using a protocol. Now that looks really very favourable, but the alarming thing that we found was that here, and you maybe can't see it too well at the bottom, the I-square shows how the variability among the studies, and you can see that they are actually quite variable. Those confidence intervals, which are the horizontal lines, quite a lot of them will actually cross the line of no effect. So there's a lot of variability, and that's 67%. The closer you get to 100%, the more variability, and this was a significant variability. When we looked at subgroup analysis by type of ICU, and here you can see we've categorised the ICUs. This is mixed ICU, this is neurological, this is surgical, and this is medical ICUs. You can see here that in general they're showing an effect for mixed, surgical and medical ICUs. But again, we're seeing variability, which is significant, even within those types of units. For neurosurgical units, there was no difference at all. They had no impact on these type of units. So we thought, okay, let's explore the variability a little bit further, and so we looked at it by protocol type. And here you see we've divided the studies into those that measured duration of ventilation when they used a spontaneous breathing trial, and those that used a stepwise reduction and support. And again, you can see variability even within those groups. Here it's not so much, it's only 39%, and that wasn't significant. But at the same time, it just about touched the line of no effect. Down here, it was clearly past the line of no effect, but there was quite a lot of variability, 75% with the stepwise reduction. So again, quite a lot of variability among the findings of trials. So we looked at it again with a type of approach, and here we've divided it into the professional-led approach. That's the protocols where we had algorithms or guidelines, and here the computer-driven, the computer-led protocols. And again, quite a lot of variability, but clearly showing an effect for professional-led. Really only 2 studies contributed data to this outcome for the computer-led. So as you can imagine, we haven't got much of an effect here in a very, very wide confidence intervals. So the subgroup analysis then by type of approach, type of unit, and type of protocol isn't really explaining very much on that variability. When we look at weaning duration is reduced by 70% of geometric mean in the protocolised group in comparison to non-protocolised weaning. Again, 97% of variability, and that can be explained by when we divide it into a subgroup analysis. SBT protocols, well, I mean, they're going to have a really short weaning duration anyway, because they're going to be set at 30 minutes or 120 minutes. So that's why they've got this wonderful looking effect on weaning duration. It's really not maybe an appropriate outcome to assess for those type of trials. But stepwise reduction also showing an effect but quite high variability. So what about the harmful outcomes? Mortality and adverse events, really using weaning protocols really had no difference and compared to not using protocols in terms of mortality, reintubation and in tracheostomy. So when we summarised our findings then, we used the grade principles to summarise the findings, and this chart shows the summary of findings table, and I just want to direct your attention to the right-hand side. Well, first the left-hand side, we reported on 5 outcomes, and we report the summary of findings and the quality of evidence for these 5 outcomes. For duration of mechanical ventilation, we have graded it as moderate, and we downgraded it to moderate because of the variability that we found in the results. And that was the same for ICU mortality and for reintubation. And for weaning duration and ICU length of stay, we downgraded it to low because of the variability and also because of the wide confidence intervals that we found. So that's where we sit with the quality of evidence for protocolised weaning. So, okay, what about children? Do they work in children? We conducted this review last year. Only 3 studies in paediatrics. Furonda's the biggest trial in Brazil, used a spontaneous breathing trial, and 2 smaller trials used a computer-led approach. And they were 2 pilot studies with only about 30 patients in each. And I'll just show you one finding from this, and that's on the duration of mechanical ventilation. You can see that they are showing an impact and reducing duration by about 30 hours on average. But although it's a significant difference, the effect is coming only from that largest trial. And so there's really limited ability to generalise. And the 3 studies didn't collect sufficient information to let us know whether protocolised weaning would be harmful to children. So where do we go from here? Protocolised weaning is a complex intervention. And it's not just about the weaning protocol. It's more than the weaning protocol, because it's the people who use the weaning protocol. It's the resources that are within the ICU and the workload that the staff have in using the weaning protocol and the time that they can spend. So these things need also to be taken into consideration. So the variability is likely to result from differences that have not been adequately described or addressed. And these studies didn't really conduct any further sibling studies to a qualitative research to describe what's happening or the satisfaction of staff or what they felt about using weaning protocols. So context and organisational processes will impact on organisation, on intervention delivery. And inconsistency in outcome measure definitions will also distort the synthesised findings. I find that many of the studies in both these reviews didn't quite describe adequately the duration of ventilation. So it's difficult to know when we put them together in the meta-analysis if they were actually all measuring the same thing. And okay, these studies spanned over the past 20 years, and you can say that maybe it was because some of them were conducted in the 1990s, but this is still a big problem. And we know this because we recently did a review looking at critical care trials that measured ventilation outcomes. We reviewed them in a number of some of the top impact factor journals. We looked at randomised controlled trials that recruited patients receiving invasive mechanical ventilation and reporting ventilation outcomes. 75%, these are some of the outcomes. Duration of ventilation, 75% did not define the duration of ventilation. For ventilator-free days, 25 trials reported it, 36% did not define what they meant by ventilator-free days. So you're probably saying, well, sure, everybody knows what that is. But to have a look just at this one slide, the duration of ventilation, the measurement time points, those that did describe it gave different start points and also different end points. So, nobody has the same understanding on what that exactly means, the duration of ventilation. So future considerations, just to finish off. Optimising the weaning process for neurological ICU patients. I think that they're a special group. They need a different type of strategy in relation to weaning, and no one has really looked at this. And I think that some future considerations, future research should maybe focus on this particular area. I also feel that we really need to be conducting an evaluation of the process of intervention delivery, because we need to distinguish between intervention, success or failure, or implementation, success or failure. So if a trial has a negative outcome, was it that the weaning protocol wasn't very good? Or was it actually that what was happening with the other components of that complex intervention, what was happening with staff and how it was implemented, was that the problem? And we really need to conduct a process evaluation alongside trials to understand the findings from trials and explain them. And we need a clearer description of the context into which the intervention is actually delivered. We need to know what's the ratio of nurse-to-patient ratio and doctors, the doctors' rounds. We need to know what the context is. It is not the same worldwide. And we also need agreement on those outcomes and also how we're going to measure those outcomes so that we can get better clarity, particularly when we conduct systematic reviews. I'm just finishing with a sneaky slide to advertise our European Federation Conference, which is coming up in January. And for the nurses, maybe I hope to see some of you there. Thank you very much.